I'm hopeful that this will give you some insight into causes of joint, muscle, and nerve pain that scleroderma patients experience. So I need to give a little background and say that the disorders that we're going to be talking about primarily are those which are related to systemic sclerosis, SSC, in that they overlap with scleroderma. In other words, they often, but not always, of course, occur in the same patient. So a scleroderma patient can have rheumatoid arthritis, can have Sjogren syndrome, dry eyes and dry mouth, can have other diseases such as lupus or polymyositis, inflammation of muscle. Now, it's also important to understand when these disorders may affect scleroderma patients and how. And so, just for background, you're probably all aware that we divide scleroderma patients into those with diffuse or widespread skin thickening and limited or restricted skin thickening. For the latter, the term that's been used in the past is crest syndrome, but we don't ordinarily use that today. Each of these subsets of disease can be divided into two categories, early and late. Now, I should have made the distinction between diffuse and limited. Any patient who at any time has skin thickening above the elbows or above the knees, meaning upper arms, thighs, chest, belly, back, those patients are said to have diffuse disease. They have diffuse disease always from a classification point of view, even though some of those skin changes may regress over time. Patients who have never had skin thickening above the elbows or knees typically have it only of the fingers, sometimes the back of the hands, sometimes the back of the hands and the lower forearms have the limited form of disease, and they never do develop more widespread skin thickening. Face doesn't count. Face can be affected in either variant. Early diffuse disease we ordinarily define as the first 3 years. Late diffuse after the first 3 years. That's just arbitrary. In the limited form of disease, early means first 5 or 10 years, late means 10 or greater years. And this is just to give you a concept of how you should be thinking of where you fit in your disease if you are a patient. And that is, the important thing is what's happening with skin thickness over time. So skin thickness I have illustrated on the left, time across the bottom. Patients with limited skin thickening have Raynaud's to begin with, later the esophagus often, but only very late in their disease, after 10 years more typically, do they develop the more serious problems of pulmonary hypertension or involvement of the small intestine with inability to absorb food or malabsorption. Skin thickness doesn't really change very much in these patients, either no change or minimal change, and it's not very much skin thickening. In contrast, patients with diffuse disease have a rapid increase in skin thickening during the first 3 years, and then it reaches a peak and begins to subside. All of the action in diffuse disease occurs early. That's when patients develop joint pain and stiffness, muscle pain and weakness, myopathy, lung, heart, or kidney trouble. Once you have reached the peak of skin thickening in diffuse disease, it is unlikely that you'll develop any new internal organ problem. Okay, so basically what I'm going to tell you is the bottom line is that pain and joint pain, muscle pain and nerve pain are typically found at different times during the illness. Joint and muscle pain are typically in early diffuse, but not in any of the other categories. So it's quite legitimate to have joint and muscle pain due to scleroderma in early diffuse disease, but the other groups of diseases, late diffuse, early limited, late limited, you need to think of some other cause other than scleroderma, because scleroderma is not the most typical cause. So let's just go through some of these to give you an idea of what types of symptoms we're talking about. Joint pain is called arthralgias, and joint stiffness, most patients attribute to the joints themselves. They identify the joints as the problem rather than locations other than the joints. And they are typically present when joints are moved. In other words, when you try to move a joint and you have pain or stiffness, then that's probably pain that originates in joints. We divide joint pain into two types, inflammatory and non-inflammatory. Inflammatory is due to inflammation, so that if you took a sample of the joint lining, you could find evidence of inflammation. It typically affects multiple joints symmetrically, right and left, small greater than large joints, so wrists, knuckles, middle joints of the fingers, predominantly affected. Very prominent stiffness in the morning, lasting more than 1 hour. And, as I mentioned, that's a symptom that occurs predominantly in early diffuse scleroderma. That's due to scleroderma. The end result is for patients to have contractures of joints, that is, they become unable to completely straighten or bend joints, particularly of the hands. Non-inflammatory is not due to scleroderma. It affects few joints. It's asymmetrical, such as one knee and the opposite ankle. Larger, greater than smaller joints, no morning stiffness. And the most typical characteristic is what we call gelling. And that's after you sit to read a book or watch TV and you try to get up and move, you are stiff. That is typically less than 30 minutes in duration, whereas morning stiffness is predominantly a morning time phenomenon. When you get out of bed, you're so sore and stiff that you can't completely move your joints, and this lasts more than an hour. So those are the characteristics that distinguish between inflammatory and non-inflammatory. Non-inflammatory is not part of scleroderma. It's due to something else. What do you see when you examine a patient with joint symptoms? Well, swelling can be present, but it's uncommon. Tenderness of the joints when you touch or press the joints is common. Swelling is something which is much more frequent in rheumatoid arthritis than it is in scleroderma. If you can't move your joints, that's common in early scleroderma, but not in the other stages. In other words, it's not frequent to have these symptoms occur in other subset and other timing stages of scleroderma. If you develop deformities of joints, that is, you are unable to completely straighten or bend them, that's common in early diffuse disease, but not at other times. So we expect joint symptoms in early diffuse disease, but if they occur in times when they're not expected, that is the other three subsets, you need to think of something else. Non-inflammatory is osteoarthritis, wear and tear arthritis, common in older patients. hip, knee, low back, big toe, etc. Also non-inflammatory is fibromyalgia, which is a frequent association of scleroderma and other connective tissue diseases, and perhaps falls into the category of a chronic pain syndrome. Inflammatory, when it's not expected, you think of something else. Does the scleroderma patient also have rheumatoid arthritis? The arthritis are related to Sjogren syndrome or lupus. Those are possibilities. Non-connective tissue disease related inflammatory conditions can also occur. Just because you have scleroderma doesn't mean you can't have another condition which is typically not associated with scleroderma, such as psoriatic arthritis, the arthritis associated with the skin rash psoriasis, or some other completely independent problem. So if inflammation of the type we described with symptoms and or possibly examination findings occurs when you don't expect it in scleroderma, you need to ask, is it caused by something else? Because the treatment might be quite different. It's a tendency of physicians always to say, well, any symptom that a scleroderma patient has is attributable to scleroderma. And I'm sure you've run into that issue before. If your left ear hurts, well, it's probably your scleroderma. If your big toe tingles, it's scleroderma. So we have to be at least aware that there are other things that can cause the problem. Okay, so how do we get at this? Laboratory testing is helpful in the general sense that blood tests that indicate inflammation, such as the sedimentation rate, ESR, and C-reactive protein, CRP, may give us a clue. If those are abnormal, then that suggests that the symptoms are not due to a non-inflammatory condition, they're due to an inflammatory condition. Blood antibodies are helpful. We know that there are many antibodies associated with scleroderma. In fact, 90% of patients have one of 9 different antibodies, and we've written articles about know your antibody. This is something that everybody with scleroderma should know. But there are antibodies associated with these other diseases too: rheumatoid arthritis, Sjogren's, lupus, and myositis. If one has joint swelling, there is often fluid in the joint that's available for analysis, and that would help to determine whether or not the condition is inflammatory or non-inflammatory. X-rays aren't particularly helpful because bone damage due to inflammation of the lining of the joint is only a late problem, and you have to have considerable damage in order to have that found on a plain X-ray. MRI is useful because it shows the soft tissues. It shows lining thickening, fluid in the joints, etc. But of course, it's expensive, but may be necessary. Okay, so that's a little bit about joints. Now, what about muscles? Muscles pain is typically appreciated in muscles. It's typically in the larger as opposed to the smaller muscles, so the muscles of the upper arm, the muscles of the thighs, and doctors use the term myalgia. Algia is pain, and my is muscle, so pain in muscles. Muscle symptoms in addition to pain include weakness, and that can be with pain or independent of pain. The most common is to have the largest muscles affected with weakness, so we call them the proximal muscles, which I've described, the muscles that control the neck, the muscles that control the ability to move your shoulders, the muscles that control the ability to move your hips, and those that allow you to do a sit-up, for example, your trunk. So weakness of those muscles is an important finding. It doesn't necessarily mean scleroderma or any other disease, but it points to myositis. Muscle cramps is another condition which can occur that favors Sjogren syndrome. Tenderness in areas of muscles, particularly at the end of muscles, where muscles narrow to become tendons, which then insert into bones. Tenderness in those areas, not in the belly of the muscle, but in the end of the muscle, are typical of fibromyalgia, and those are called trigger points. So what causes muscle symptoms in scleroderma? Myositis, in other words, an overlap with polymyositis, certainly possible at any time during the course of scleroderma. Non-scleroderma causes, the most important probably would be fibromyalgia and medications, in particular the medications that are used now to control cholesterol and other lipid abnormalities. The statin drugs may be useful for scleroderma actually, but may cause the symptoms of muscle pain shortly after they are initiated. And then other conditions independent of scleroderma, such as deficiencies of particular enzymes that lead to non-scleroderma related muscle pain and or weakness. A low blood potassium can cause weakness, not pain, and that can be due to a diuretic, but it can also be due to loss of potassium in the urine, which occasionally occurs in Sjogren syndrome patients. And cramps, as I've mentioned, Sjogren's. How do you test for muscles? Well, the doctor asks the questions and does the examination looking for weakness, inability to raise the arms up above the head, inability to bring your head up on your chest when you're in the lying position, difficulty doing a sit-up, difficulty getting out of a low chair. If those are painless activities, then that certainly suggests a primary disease of muscle. The substance CPK, creatine phosphokinase, leaks into the bloodstream during muscle damage and is measured by a simple blood test. An EMG is needle testing of the muscles. It's sensitive. In other words, if it's normal, there's probably nothing wrong, but it's not specific. In other words, it doesn't tell you necessarily whether you have muscle inflammation. MRIs of muscles can add information, and the most reliable information comes from a biopsy of muscle. And typically, we use the EMG to direct the site for a muscle biopsy. So if I have a patient who I think has weakness and an elevated CPK level, for example, I would send the patient for needle testing of the muscle, and typically those are done by neurologists or physical medicine and rehabilitation doctors. They do one side of the body, tell you what's the most abnormal muscle, and then you biopsy the opposite side. And the reason for doing that is that needle testing itself can cause an artifact in the tissue, and you wouldn't want to biopsy a place where a needle was because you could be fooled into thinking that there's inflammation there. Okay, so that's some things about muscle. But I'll get back to other issues in a little bit. I find that nerve symptoms are underappreciated by both patients and physicians. Not underappreciated necessarily, but their cause is not explored enough. And the 4 symptoms that you should be aware of for nerve are numbness, tingling, pins and needles, and burning. Any or more than one of those symptoms certainly suggests that nerve is affected. Remember that nerve supplies skin, but it also supplies other tissues, including muscle, so that muscle weakness can be caused by damage to nerves that supply muscles, in addition to muscle inflammation directly. And then the central nervous system can be affected too. Memory loss, so-called brain fog, those are not scleroderma issues. Scleroderma doesn't affect the nervous system primarily. Those you have to think of something else. The something else to think of is typically Sjogren syndrome. When a doctor examines a patient with nerve complaints, you look for loss of function of the nerves or loss of function of the muscle that supplies the nerves, or something that suggests that the brain is disordered. So neuropsychiatric testing can be done to determine whether patients have normal brain function. And those are sometimes helpful, particularly in Sjogren syndrome. But in general, scleroderma does not affect nerve. So you should think of some other disorder in that circumstance. Okay, so what are the causes? Injury to a nerve of feeling, injury to a nerve of strength, of the muscle, strength, and those are things that occur in the extremities, typically, arms and legs. So they are the peripheral nervous system. The brain is called the central nervous system. And one other nervous system that you should be aware of is the autonomic nervous system. That's the nervous system that controls things that we don't control voluntarily, such as heart rate, blood pressure, digestion, all those nerves that stimulate the muscles to allow the esophagus and the intestine to contract appropriately so that food can be passed through the intestine. Those are the autonomic nerves. And so all of those nerve areas, peripheral, central, and autonomic, can be affected. There are areas where there is external compression of nerve, and one of those is the carpal tunnel. Carpal tunnel syndrome can occur, or often occurs, because there's inflammation of the lining tissues around tendons in the wrist that press on the median nerve, which is the nerve that supplies feeling to the thumb, long finger, and index finger, and that's a cause of carpal tunnel syndrome. If it's both-sided, bilateral, then you think of disease as causing it, a connective tissue disease, for example. If it's one-sided only, then you think of something else. Maybe it's occupational, maybe it's a previous fracture, other things which do not suggest that it's due to the underlying disease. Reduced blood supply to nerve is also a cause of nerve dysfunction. Scleroderma does not cause blood vessel inflammation, vasculitis. Sjogren syndrome can, lupus can, rheumatoid arthritis can, but scleroderma doesn't. Scleroderma affects the blood supply, but only by hardening and thickening and narrowing of blood vessels, not inflammation. So Sjogren syndrome should be the most common thing that a doctor thinks about when nerve dysfunction occurs in a scleroderma patient or a non-connective tissue disease related issue. How do you test for nerve? Again, electrical testing. There are often, if a patient complains about numbness, tingling, pins and needles, burning in the feet, certainly suggesting that the peripheral nervous system supplying the skin is abnormal. Often the electrical testing is normal as well because it can't identify the tiny abnormalities of the tiny nerves that supply sensation to the feet, for example. There are skin biopsies which can be done, which can be stained to determine whether or not the small nerves are either absent or diminished in number or affected in some way. We talked already about EMG and neuropsychiatric testing. Even the brain can be biopsied safely in most circumstances if that is necessary. The way to determine autonomic nervous system abnormality is a test called the QSART, Q-S-A-R-T. And just to make it simple, that's a tilt table test on which you are placed on a table and your position changed rapidly to try and determine whether or not your blood pressure and pulse react normally or react abnormally. And some other testing that goes along with that. But those are tests which can be done which help to confirm that the autonomic nervous system is abnormal. So this patient is a 45-year-old woman who has had limited scleroderma for 20 years, so category late limited, right? There are certain things which ought to come to your mind here right away. In other words, that's not somebody who is in the early phases of diffuse disease who would expected to have joint pain and stiffness. Dry eyes and dry mouth for a number of years, suggesting Sjogren syndrome. Fatigue, new pain and stiffness, and mild swelling of the wrists, the knuckles, and the middle joints of the fingers for the last 6 months. Sedimentation rate and CRP test slightly elevated, and the test for Sjogren syndrome antibodies, anti-SSA, positive. So here's a situation in which you would say, okay, this is a patient who has joint pain and stiffness, which is new. It's inflammatory because it's both-sided. There's stiffness affecting these joints. And it's in a time frame in which it's uncommon to be due to scleroderma. So the odds-on favorite here is that this is due to Sjogren syndrome. And in that circumstance, a different approach to treatment might be used. In most cases, we would use some combination of low-dose cortisone and or Plaquenil. And I imagine many of you have heard of Plaquenil. Plaquenil is an anti-malarial drug used to prevent malaria in endemic, epidemic areas throughout the world, but in the 1940s recognized to be helpful in rheumatoid arthritis, lupus, and Sjogren syndrome. So it's a drug which we often would use, but we wouldn't use it for scleroderma. Okay, so the diagnosis is Sjogren's with arthritis, and that would be the treatment. Okay, another one, 60-year-old woman, diffuse disease for 8 years. And so that's late-stage diffuse, minimal residual skin thickening. In other words, the extensive skin thickening resolved. So perhaps all that was left was thickening of the skin of the fingers and maybe the hands. New painless weakness of the shoulders and hips. Couldn't raise her arms up over her head, had difficulty getting out of a chair. The CPK test for muscle inflammation elevated, and needle testing of the muscle abnormal. So that's a patient who has developed myositis, and most likely, and if you went ahead and did a muscle biopsy, you would probably find muscle inflammation. If you don't treat it more aggressively, the patient would end up with certain amount of permanent, in other words, non-reversible muscle weakness. So the diagnosis is polymyositis occurring in a patient with diffuse scleroderma, an overlap, so to speak, and low dose or moderate dose cortisone plus methotrexate, one of the drugs frequently used in rheumatoid arthritis to treat arthritis, would be one of the approaches that one might use. I'm not a fan of methotrexate to treat early diffuse scleroderma. I don't think it's useful. And I imagine you've heard the warning that to use cortisone of any dose, especially high dose, is risky in patients with diffuse scleroderma early in disease. Why? Because it can bring on kidney involvement, so-called renal crisis. So we stay away from any cortisone dose, if possible, in patients with early diffuse scleroderma until they have reached and passed the peak of skin thickening, in which case it is much less risky to use cortisone-containing medicines. Okay, here's a third one. An older woman, I shouldn't say older, should I? Limited disease for many years, along with Sjogren's, numbness and pins and needle sensation in the feet and toes, memory loss. Now think about which nervous system is affected, the peripheral, right, feet and toes, the central nervous system with memory loss. Nerve testing showed that there was something wrong with the nerves of sensation in the legs, and an MRI of the brain suggested that there were multiple abnormal spots in the white matter part of the brain. So this is an example of a patient with long-standing limited scleroderma who develops nervous system findings, but scleroderma doesn't affect the nervous system, Sjogren's does. So the diagnosis would be Sjogren syndrome with peripheral and central nervous system involvement. There are many ways that you can help treat the numbness in the feet. You've heard of Neurontin and Lyrica, medicines which presumably help to minimize nerve symptoms in this circumstance. But because the brain is affected, you have to consider much more potent treatment, such as immunosuppressive drugs, Cytoxan, et cetera, et cetera. So those are examples of circumstances in which the joint, muscle, and nerve symptoms are not actually due to scleroderma, but due to disorders which scleroderma is associated with. Something I didn't mention, which I should have, got lost in the shuffle there, hypothyroidism, underactive thyroid, very frequent in scleroderma, much more common than it should be in the general population, sometimes autoimmune, sometimes due to immune inflammation of the thyroid. In that circumstance, it's called Hashimoto's thyroiditis. You can biopsy the thyroid and find immune system cells, lymphocytes, in the thyroid gland, destroying it, and antibodies against the thyroid are found in the blood. Patients with hypothyroidism can have muscle pain, not weakness so frequently, but muscle pain. So another consideration in someone who has myalgias would be hypothyroidism. So you'd have to check the thyroid function studies and the antithyroid antibodies. And if that's the case, then administering thyroid supplementation cures the symptoms. Not immediately, but within a couple months. Okay, so questions?
It took me a long time to be diagnosed with a hypothyroidism because the levels just didn't seem to be low enough. But I was symptomatic of all the things that go with it, the tiredness, the weight gain, the whole bit. Is that common for it to...
Yeah, so the question is, if the laboratory tests are not dramatically abnormal, can you have symptoms? I think yes. I think you can, perhaps a little bit unusual. But the diagnostic test would be if you receive thyroid supplementation and within 2 or 3 months the lab test normalizes and your symptoms go away, then you can say, okay, that's probably what it was.
Yeah. I had a doctor that did not want to treat it because of that, and a different doctor said, no, I think that's what we're dealing with. And sure enough, you're right, the levels came up right after they put me on the thyroid, and it made a big difference.
Yeah, so I think that's the proof positive in that circumstance.
Okay, my question has to do with if your symptoms or if a patient's symptoms are asymmetrical, it's always like one limb or something, would that usually imply like something totally different, like an injury or something, rather than autoimmune symptoms?
Yes. Typically, autoimmune diseases don't respect sides. It's right and left, typically.
My question is, if you had
Where are you?
I'm on the back right here.
Okay.
I'm looking at my notes. On case example number 3, it talks about the multiple spots on the brain. Are those going to change, or do they change, or they stay the same, or do they multiply, or do you think those?
Well, they came at some period of time, and neurologists typically would follow the MRI to see if there are subsequent changes, and would also follow the patient to see if there's any what we call cognitive changes. So you wouldn't necessarily treat something which perhaps occurred 5 years ago and wasn't progressing.
Yes, sir. Okay, the other part to that question is, if talking about the hypothyroidism, if there's a goiter with the thyroid, should it be treated, and how?
Should borderline
Goiter.
hypothyroidism
Goiter, should a goiter?
A goiter, I see. No, a goiter is simply defined as an enlargement of the thyroid gland. And so there can be many causes of goiter, one of which is autoimmune, but others are thyroid cysts, which don't have anything to do with connective tissue disease. Another important one is thyroid cancer, which is not an uncommon disease and which is more frequent in patients who have autoimmune hypothyroidism. And the way you get at evaluating the thyroid for the consistency of it is ultrasound. So ultrasound of the thyroid is done in circumstances where a patient has a goiter, because you want to find out whether there is a cyst, a tumor, a complete evidence of widespread inflammation of the thyroid, for example. And in the circumstance where you can't tell, a thyroid biopsy is often done.
Well, if this person has Sjogren's and a positive ascentromere, is that associated?
No.
Okay, that wouldn't be
Patients with anti-centromere antibody and limited scleroderma, that's a common association, more frequently have autoimmune hypothyroidism.
Okay.
But a goiter has to be evaluated separately, because most patients with scleroderma and hypothyroidism don't have an enlarged thyroid. In fact, they have a thickened, scarred thyroid, which is small.
The other question was on the case number 1. You're talking about the treatment with cortisone and the Plaquenil. Is that long-term?
Not necessarily. Typically, the treatment with cortisone is a quick fix, and with Plaquenil is the maintenance medicine. But Plaquenil does not typically take effect earlier than 3 to 6 months, and sometimes 6 to 9 months. So we would typically use low-dose cortisone in the first 3 months of treatment, as outlined in this particular case, and then try to reduce and discontinue the cortisone and leave as the maintenance medicine only Plaquenil. That doesn't always work, but that's the intent.
I just have a question regarding the diagnosis of Sjogren's syndrome or Sjogren's disease. So if you have a patient with dry eye and mouth, or the Sika syndrome, but has some joint symptoms, but does not have a positive antibody test, would they then not have classic Sjogren's?
Yes, the question is revolves around how you diagnose Sjogren's. Now, the antibody testing is present in the majority of patients who have Sjogren's syndrome alone, but in the minority of patients who have what we call secondary Sjogren's. In other words, Sjogren's appearing with the diagnosis of rheumatoid arthritis or scleroderma, for example. So perhaps only 20% or 15% of our scleroderma patients who have Sjogren's based on other findings have that antibody present. The way we would usually evaluate a Sjogren's patient with scleroderma for Sjogren's is to send the patient to an ophthalmologist and ask for a formal dry eye testing to be done. And there are tests that ophthalmologists do which can give important clues to reduce tearing. There are other causes of reduced tearing also, such as disease of the glands around the eyelashes, medications. So it is not certain that a patient has Sjogren's syndrome if the ophthalmologist says you have reduced tearing. But if the ophthalmologist says you have reduced tearing and I don't find another reason for it, then that would be the likely diagnosis. If the abnormal tests are quite conclusive, then there's no question. The other thing that we sometimes do is a lip biopsy. Saliva is produced not only in the large saliva-producing glands, the parotid glands, and the glands underneath the tongue, submandibular glands, but also in the tiny glands all throughout the mouth. And so you can make the diagnosis of Sjogren's syndrome by doing a biopsy of the inner part of the lip and finding lymphocytes, cells from the immune system, which are not supposed to be there, in moderate or large numbers. The same thing can be found in the lacrimal gland, the gland that produces tears, although that's seldom done as a biopsy test. But that's the rationale for Sjogren's syndrome. Sjogren's syndrome is caused by lymphocytes getting into the saliva-producing and tear-producing glands and interfering with their function. I'm not a big fan of the lip biopsy because it is, after all, a sample. And if you don't get it's a patchy disease. So if you get an area which is unaffected and the biopsy comes back negative, I'm not sure that I would give up the diagnosis of Sjogren's syndrome if it fits in other respects. So I'm one who has a tendency to say if other things seem to fit that picture, then the best thing to do is to give the patient an empiric trial of low-dose cortisone and Plaquenil, perhaps a 1-year trial, and then you try to make up your mind after 6 months or 9 months or a year, has it been effective or hasn't it been effective? I would also, in that, I guess it's the first patient, the patient with joint pain and stiffness, I would sometimes give the patient a 2-week or 3-week course of cortisone. Cortisone is anti-inflammatory, but it isn't a pain reliever. And so a patient has pain and stiffness that gets dramatically better with a 2-week course of low-dose cortisone. That certainly suggests an inflammatory process. So I would head in that direction in my thinking and treatment. Yeah.
Doctor, I was wondering if there is a standard amount of Neurontin that is given for the nerve pain that is effective, or is that just an individual situation?
Yeah, the question is dosage of Neurontin or Lyrica.
Yes.
No, it's quite individual. I think most patients, according to neurologists, have their symptoms primarily at night, and so nighttime dosing is the most common, but a dose as low as 100 to 300 milligrams a day may be effective. In other circumstances, you may have to go to a dose of or 2,700 milligrams per day. Obviously, side effects can interfere with your ability to tolerate that high dose.
Hi.
Yes.
I noticed you had statin drugs in parentheses up there. Statin drugs?
Statin drugs,
Statins?
correct.
How do they actually work in this particular case?
Well, they cause muscle damage. And I'm not sure that the mechanism is known. There is, in some patients, an immune reason for that. And investigators from Johns Hopkins have found an antibody in the blood in patients who have prolonged symptoms after a brief course of one of these drugs, which is present in some fair proportion of patients. But the general gist is that statin drugs interfere with metabolism. They prevent cholesterol formation and or accelerate its degradation, and the idea is that you can avoid atherosclerotic or hardening of the artery heart disease by using these drugs in patients who have high cholesterol, high triglyceride, and so forth. So they interfere with metabolism of lipids, which are the fatty substances.
Right.
They do the same thing in muscle. They interfere with the processing of lipids. And sometimes we need lipids, the products of lipids in muscle to generate muscle power. So patients who have a limited ability to use fat for metabolism in muscle can have significant symptoms when they try to exercise. I don't know enough about it to be more precise, but that's the general gist, is that they do something to interfere with the metabolism of substances which provide energy for muscle. And typically, the symptoms come within a few weeks of the beginning of a statin drug. If the drug, and they can be associated with high CPK levels or not, but mostly yes. And once you stop the medication, the symptoms disappear rather promptly, within a couple weeks.
I have severe thigh muscle pain in my thighs when I walk.
I'm sorry, I can't hear you.
I said I have muscle pain in the thigh when I walk.
Thighs when you walk?
Yeah, it limits the amount of walking I can do, and I just stop in my tracks.
That's a circumstance in which you would think of poor blood supply or a deficiency of an enzyme. And
Okay.
so poor blood supply could be due to many reasons. Typically, if you have hardening of the arteries, you have pain in your feet when you try to exercise rather than pain in the large muscles. But this is a circumstance in which you should ask, do I have a metabolic myopathy, a muscle disease caused by some problem with the metabolism in your muscle? And we do see patients, rarely, who have enzyme deficiencies, presumably from birth, but which only show up in their 30s, 40s, 50s, or 60s.
So you don't think it's the scleroderma or the
Not scleroderma.
How about the overlapping RA that I have?
No.
No. Okay.
Not rheumatoid arthritis for muscle.
Okay. Thank you.
Oh, go ahead. Okay. Hey, Dr. Medsger, I want to welcome you to Atlanta again. I am your patient. I come to see you about every 6 months.
You look different.
I look
Where's your gown?
Yeah, I know. I had the Sjogren's, and on case number 1, you have the Sjogren's syndrome with the arthritis. And then case number 2, you talk about the pain, the weakness of the shoulders and the hips. And now what's happening to me is that I have it in my shoulders, a lot of stiffness and pain. In my elbows, I'm getting a lot of burning. I was trying to see, well, of course, I guess I'll see in September, but if I might have the polymyelitis, if it's
No,
go-
it's probably unlikely. Those are probably joint symptoms rather than muscle weakness.
Okay.
And we've checked your CPK in the past, it's been normal. So it's unlikely
Okay.
that that's the case.
Thank you.
Okay, last question.
In scleroderma, do you not ever see a hardening or thickening of fascia that would cause pain?
No, fasciitis is a different disorder.
Okay.
Fasciitis is one of the forms of localized scleroderma. But typically, scleroderma affects the skin, and if there's muscle involvement, the muscle. But what's between the skin and the muscle? It's fat and the fascia. But scleroderma does not cause fasciitis.
Okay, thank you.
The first case study that you showed was the woman that had scleroderma for 20 years, and then the last 3 years she had a flare-up. How common is that, a late-stage flare, significant flare-up like that?
Well, what I'm trying to tell you is if something happens in late stage limited disease, it's not due to scleroderma. It's due to something else.
Okay, so Sjogren's.
Correct.
Okay.
In this circumstance. It could be other things. I could have made up other cases that illustrated other reasons to have late problems.
Okay, but it is not uncommon then to have a chronic disease such as scleroderma and then have a scleroderma flare up at the end?
It is uncommon. Scleroderma is not the likely cause of symptoms which first occur after 10, 15, or 20 years after the onset of scleroderma.
Okay. Have
You
you ever
have to
seen
think
it?
of something else.
Okay, well, it's definitely Sjogren's but skin tightening like scleroderma, could it be rare, or is it just unheard of?
If you had diffuse scleroderma within the first 5 years, there is some possibility that you would have a recurrence of diffuse scleroderma.
Okay.
In other words, that would be with widespread skin thickening.
Yes, yeah.
The likelihood of that goes down with time, so that in years 5 to 10, after the beginning of diffuse scleroderma, the likelihood of going from a low skin thickness score, which we know how to measure, to a high skin thickness score, for example, going from less than 10 to more than 20, when the maximum is 51, that likelihood goes down with time. So in years 5 through 10, after the beginning of your disease, if you had diffuse scleroderma, not limited, but diffuse, then the likelihood would be somewhere around 10%.
Okay, all right.
If this occurs in years 10 through 15, the likelihood is 5%. We don't have data for years 15 through 20, but the anticipation would be an even lower likelihood of having a recurrence of diffuse disease. So diffuse disease is a monophasic disease. It occurs in the beginning, it reaches a peak, the skin actually gets better, and it is unlikely that it's going to resurface. So that's all I had to say. Thank you for your attention.